Good afternoon, everybody. My name is Tolip Mirzoev. I'm Professor of International Health Policy and Systems at the University of Leeds, and I'm going to share on behalf of the large team, whose names you can see on the slide, our experiences of tracing realist theories in the context of large-scale program in Nigeria. Um, Between 2012 and 2015, the government of Nigeria has implemented the Fuel Subsidy Reinvestment and Empowerment Program, in which they have invested the savings from the fuel subsidy removal into the social protection program. And one component of that program involved improvement of maternal and child health in clusters of 4+1 facilities in selected states in Nigeria. So the program, which was called SURE PMCH, involved two components. This so-called supply component, or the health systems improvement, which involved deploying and training about 2,000 midwives, 9,000 village health workers, and 1,000 community health extension workers, improving the infrastructure in health facilities and provision of equipment, supplies, and medicines. And on the demand side, the program involved provision of the conditional cash transfers to pregnant women for attending the antenatal care services, for delivering in health facilities, and bringing their children for vaccinations. And the program also involved mobilization of the ward development committees as part of the community engagement in health services. So the study, which I'm going to share with you, was called REVAMP. So it stands for Determinants of Effectiveness and Sustainability of a Novel Community Health Workers Program in Improving Maternal and Child Health in Nigeria. And it was implemented by a partnership between the University of Nigeria, Enugu Campus College of Medicine, called COMINEC team, in collaboration with the Leeds team, headed by myself. And you can see the names of all the key co-investigators. So on the Cominex side, it's the Professor Udzo Chikwu was the PI, and I was the overall PI for the project as a whole. And the Leeds team included Dr. Anna Manzana, Professor Tim Enser, and various other colleagues too. So Revamp aimed at assessing effectiveness and sustainability of achieved changes from the program. So it was implemented in Anambra State in the south part of Nigeria in 3 clusters. One cluster was the kind of where the program was implemented, largely the supply component, SURE PMCH. The second cluster was where the additional conditional cash transfer component was added. And the third cluster was the control cluster with no implementation. So Revamp study was a cross-disciplinary and mixed methods realist evaluation. So it kind of followed the 3 classical steps in realist processes: theory, gleaning and development, testing, validation, and refining, consolidation. And in terms of the specific methods, we use the combinations of document reviews, in-depth interviews, focus group discussions, and on the on the quantitative side, we have conducted the facility exit survey, the household survey. We've also analyzed the data from health management information system, costing data, and so on. And more details about the project methodology is available in the published study protocol in the implementation science. And today's presentation was is largely based on another paper on the right-hand side of the screen with exactly the same title as the title of my talk. And all papers published from this study are available as open access. So I would very much encourage you to track them down and have a look at more details. So the project involved three broad phases. So the first phase, as I mentioned, was very much about gleaning theories, and it was about 5 months long, whereas the second and third phase involved theory development, testing, validation, and consolidation, and each of those phases were about 2 years long. During the project, we have, as you would expect, developed and reshaped the different program theories. So we have started in the first phase with the overall theory of change, as we called it, that summarized the logic of the program. And then later in the phase one, we have actually followed the architecture of the program, and we have developed or rather subdivided overall program theory into supply and demand side logics. And later on, we have developed more specific four supply side theories and four demand side theories shown in the middle of the slide. And over the period of the 2 years, those were tested, validated, and then reshaped into slightly different configurations of the theories. And that's what you can see on the right-hand side. So in this presentation, I will specifically go through the processes that we went through in tracing the realist theories in relation to two of those 8 theories from the phase two. The theories around trust from the health service users towards the healthcare system that determines the utilization of healthcare services, as well as the notion of security, again from the health care users, but also from the perspective of the health service providers that determines the provision as well as utilization of healthcare. So during the first phase, we have, as you would expect, engaged in depth with program documentation. We had various in-depth discussions with program architects. We're also assessed quality of the HMIS data and engaged with the literature. And then we met in Leeds and kind of deepened our understanding of the program. And from there, eventually, we published a paper reflecting on our experience in logic model development. But also, we kind of started developing the initial theories, the supply and demand side theories. And the capacity strengthening on realist evaluation that was initiated in Leeds was then followed up by the step-down capacity workshops in Enugu. And on the left-hand side, you can see Dr. Anna Manzana and Dr. Bassi Ebenso facilitating one such webinar at a distance through the combination of GoToMeeting, phone calls, WhatsApps, and various other platforms. So on reflection, phase one was very much kind of driven by the program logic, hence the supply and demand side breakdown of the theory. Neither security nor trust were explicit in neither in the data nor in the project documentation. They were sort of the meant and cutting across the working environment, infrastructure, staff performance issues. Security was a little bit clearer featuring in the data in references to perimeter facing and night guards, but trust emerged more indirectly in references through to staff motivation and user satisfaction. And as I'd mentioned earlier, we have engaged with the literature, but on reflection, our engagements with literature was largely at the level of empirical literature rather than substantive science theories. And our engagement was very much driven by the program logic at this stage. In phase two, our engagement with literature was progressing through to more balanced empirical and theoretical. Our data collection had a larger scale, so we had 96 in-depth interviews. We collected and analyzed costing data and conducted household survey. Data analysis was done in 5 groups over 4 weeks. that culminated into then eventually a 2-day workshop in Nigeria in February 2017, at which 15 themes were identified and then grouped into 8 program theories that I'd mentioned earlier. So reflecting on the themes, security was very much a distinct, clear theme number one, whereas the trust was cutting across some of the other themes, specifically availability of different commodities, drugs, equipment and consumables, training, supervision, as well as relationships building. And they reflected kind of the different nature of those two phenomena, security and trust. So this is just an example of what the security theory was looking like. As you can see, we have disentangled and identified the specific contexts, specific mechanisms, and specific outcomes. And we have kind of articulated the narrative into a causality proposition. And on the right-hand side, you can see one of the theories of trust that eventually consolidated into a distinct theory that dealt with sustainability of trust in the healthcare system. And that followed the same logic with clear identification of key contexts, mechanisms, and outcomes, and articulating the causality propositions there. So on reflections, we have engaged more explicitly with retroductive reasoning during this phase. So our tentative causality propositions included more explicitly in the articulation of the theories, but they were also tested in subsequent in-depth interviews. And we have used the magnifying glass metaphor, during which we have engaged with both empirical and increasingly theoretical literature. During third phase, we have had largely kind of regular meetings within and between the teams in Leeds and in Nigeria. Our scale of the data collection was much smaller, so we had 39 interviews and focus group discussions, but we felt our engagements were much deeper with sort of at an analytical level. And we have kind of worked with substantive theories more clearly in the what we call the social lab. And in the process, what we did is we have developed what we call the knowledge summaries, in which we have specifically identified individual contexts, individual mechanisms and outcomes, and we have summarized our emerging results in the form of arrows linking specific C's, M's, and O's. And that informed the refined version of our narrative, but also it informed our specific CMO configurations, which were driven by the arrows. So just to give you an example of some of the findings that were emerging, a couple of quotes. The left top left corner gives you an idea of a petty trader who accompanied a pregnant woman with her husband to a health facility at night, who were then waiting for a long time before the gates were opened. And on the right-hand side, the same sentiment was kind of echoed by the policymaker that security is an issue, but they also added that there are limited resources within the Nigerian health system to actually adequately ensure appropriate security. The findings of security program theory are actually been published in a separate realist paper in BMC Health Services Research Journal. So the citation is at the bottom of the slide. So I would very much encourage you to have a look, and any feedback is of course very much welcome. So in terms of the trust theory, we followed the same approach as with security. So the knowledge summary, was sort of synthesizing the specific findings and relating specific contexts and mechanisms and outcomes. Within the context, we have differentiated between the macro level as well as the meso and micro institutional contexts. And within the mechanisms, we have disentangled between the reasoning part of the mechanisms and the intervention. So we felt it was important. And of course, the narrative was kind of reflecting our increasingly refined and validated version and understanding of this theory. So similarly to security, the findings that were informing the different arrows were very much emerging from the data. And on the left-hand side of the screen, you can see a couple of quotes from service users who were really echoing kind of the importance of different incentives in fostering trust. On the right-hand side, I've included a quote from one health worker who reflected that actually withdrew the end of the SureP MCH program signaled slight deterioration of trust because various incentives were stopped to be provided. But at the bottom, you can also see a quote from another health worker who actually reflected that on the notion of the residual trust, even though SureP MCH program was stopped eventually, but some people continued to use health services as a reflection of their increased confidence in the health system. So our theoretical engagements with literature were different between the two theories. In terms of security, we drew throughout on complementary body of interdisciplinary literature covering fear of crime and gender, as well as fear of crime and the structural factors and different sort of determinants of security, such as kind of political, economic, and sort of social issues. Whereas in relation to trust, I think our engagements with literature were kind of very much reflecting the different stages of the evolution of this program theory. So we started with micro, meso, macro distinction of the determinants of trust. Then we progressed through to clear identification of the different factors. And eventually, particularly for residual trust, we housed our program theory in the social capital theory. And that was an interesting kind of distinction between the two theories. We faced three conceptual challenges. First, in relation to the kind of levels of abstraction, we toggled between the different levels of from specific CMOs all the way through to the kind of substantive theories at the level of the middle range theory. The second challenge was the usual kind of what causes what, moving and resolving the different overlaps and sort of discrepancies and repetitions between the contexts, mechanisms, and outcomes, and trying to avoid the circular arguments. And last challenge was kind of basically just decisions which theories to use, and that was resolved through iterative dipping in and out of the literature against the data. So on reflection, neither security nor trust were explicit in the initial program's design. Security clearly emerged earlier as a distinct theme, perhaps as a more tangible concept, whereas trust we felt was a bit softer and cross-cutting. The data set for security was exclusively qualitative, whereas the data for trust also included some of the quantitative results, and maybe that helped us to articulate these as a distinct theme cutting across the different issues. And we also felt that our cross-disciplinary expertise in social sciences, economics, statistics, and health policy and systems research really helped us to engage with the substance deeper. So what have we learned? So our overarching lesson learned is that realist evaluations are important, though time-consuming approaches to generating practical implications for policy and practice. We also felt that it is important to pitch theories at the right level of abstraction for maintaining the balance between rigor and policy relevance. We found that sourcing different nuggets of evidence can be a challenge in resource-constrained settings of low and middle-income countries. And retroductive approach to realist evaluation requires expertise, but also continuous engagements, which can be a challenge for multi-partner countries. That's all from me. If you are interested, please have a look at our website. Please feel free to email me or follow me on Twitter. Thank you very much, and I'm happy to answer any questions.